Alrighty, we are going to go ahead and get started. So again, thanks for joining everyone for today's webinar, which is Enterra Therapy in the ASC, what surgeons need to know. We are so grateful to have Dr. Michael Hughes with us to facilitate today's session as well. Um, my name is Colin Schmidt. I'm with Enterra Therapy and will be the moderator for this session. Also with us today from our team is Tiffany Stanley, who is a reimbursement specialist. She will help give an overview of reimbursement for Enterra Therapy and also help answer any questions you have on the topic in the second half of the session. So today's session is going to provide practical strategies for starting and growing a gastroparesis practice, including clinical insights and program considerations with a focus on the ASC setting. One just housekeeping item, please submit your questions in the chat at any time throughout the session. We will be addressing them during dedicated Q&A during the second half of today's program. And like I said, we're honored to have an exceptional faculty member, Dr. Michael Hughes, with us today, who is the attending surgeon at Premier Surgery Center of Louisville, Louisville Surgical Center, which is also in Louisville, and PMC Regional Hospital in New Albany, Indiana. Dr. Hughes has been implanting Enterra Therapy for over a decade. He started doing these in a university setting as a transplant surgeon and is now doing them solo in a private ASC setting for the past 6 years as part of his gastroparesis-centered practice. And a fun fact, he has done more Enterra Therapy implants than anyone else in the world. We just chatted about this, and he's done over 2,000 at this point and has stopped counting. He's a fantastic resource and advocate for gastroparesis patients and their physicians. So, Dr. Hughes, we're very excited to have you here and look forward to an engaging discussion. And with that, we can get started.
All right, thanks, Colin. So the way I got into all this is I did my transplant surgery training at the University of Minnesota. And as some of you may know, we do a lot of pancreas transplants there. So we had a lot of very brittle type 1 diabetics. And part of my transplant training was learn how to place gastric stimulators, the Enterra. And so when I came to the University of Louisville as director of the pancreas transplant program, I started placing the Enterra to help out our transplant folks. But the need for the Enterra rapidly escalated to the point where I was doing over 300 of these per year, not on my own. I was doing them in conjunction with Dr. Tom Abel, who really helped pioneer this field. And it got to the point where I had to pick transplant. Do I want to keep being a transplant surgeon, or do I want to break off, start my own practice, and do the gastric stimulator stuff? About the same time, I became a single dad with a 6-year-old and 9-year-old I was taking care of without any family in town. So I decided to start Vanguard Surgical, really just to focus on gastroparesis patients. And the lifestyle is much easier doing that than doing transplants. I don't really have virtually any emergencies. I rarely have patients in the hospital, and nearly all the cases I'm doing can be done in the ASC setting. So the agenda for today is one, we'll go over the challenge of gastroparesis, which I look more as an opportunity than a challenge. And then two, Enterra Therapy overview and supporting data. Three, why do this in the ASC? Why not just do it in the hospital? Well, I have some perspectives on that. And then specific patient and practice considerations if you're looking to start it in an ASC. And then if you're looking at starting it, what do you need to do in advance to get buy-in by the medical leadership as well as the business leadership of the ASC? And then how do you want to get it going and ensure that it runs smoothly without any snags? Because as you guys know, these are critically ill people that a lot of providers are a bit nervous taking care of. And then finally, at the end, they'll do a Q&A session where I can answer any questions you guys might have, or the other Enterra staff can help out answering questions. So like I said, the challenge of gastroparesis, I look more as an opportunity. Yes, these are really sick people, but the reason why I like doing it is for, in large part, the same reason I like doing transplants. I like making people's lives better and seeing them get better. And being able to do the Enterra as well as the other tools we have in our toolkit now, which are a whole lot better than they were 10 years ago when I first started doing this, I can get the vast majority of patients where they've regained control of their life. They're not thrown up anymore. Their pain's gone. Their nausea, if they have it, is manageable and intermittent and infrequent. And they no longer feel like gastroparesis has ruined their lives. And I mean, people like cry, people hug me. I mean, it's really rewarding doing this work. So gastroparesis is just a rough disease until we can get it turned around. So 64% of gastroparesis patients visited the ER within a year of diagnosis. And of those that were admitted, they had on average 3.6 visits per patient. That's a lot of in and out of the patients. Some of my patients are in and out of the hospital more times than they can count. On average, the length of stay is 13 days. It's not like they just get admitted, they do a whole lot better, and you discharge them home. They can be there and languish for quite some time. And then 27% of patients end up having a readmission within 30 days, which gets hospitals in trouble. And then the hospitals aren't too keen on taking care of these patients. But once you start initiating this therapy, the readmission rates really dramatically go down. And this is just a map of the prevalence of gastroparesis. You can see most of it's centered around metro areas, which you would expect for any disease process, really. And it's estimated that about 700,000 patients have gastroparesis. There's about 2.5 million Google searches for gastroparesis. So there's tremendous patient need, people seeking therapies because they feel like they're not getting the therapy they need, which is part of the reason why when they come and see us, they love us because we believe them, we listen to them, we tell them we can make them better, and then we follow through. And then this isn't a rare thing that's been done. Over 17,000 patients have received Enterra Therapy. And one of the studies I find the most interesting is the one cited below the map, which is one of the longitudinal Framingham studies, where they looked at gastroparesis symptoms over time, and they estimated that delayed gastric emptying is most likely occurring in about 1.8% of patients. So now getting on to Enterra Therapy overview and supporting data. This is pretty straightforward. There's two procedure types. Essentially, there's new implants, which are about 60 to 90 minutes. Outpatient procedures done minimally invasive. A lot of surgeons do this robotically. I do it all laparoscopically because I don't have a robot at the ASC, and I'm doing it 60 to 90 minutes. It takes that long, not because it's a complicated operation, but there's a bunch of little steps, and you have to do an endoscopy in the middle of the case, where I break scrub. I go around, do the endoscopy myself, and then break back into scrub. And then there's generator replacements. People call them battery changes, but it's confusing for patients. Really, the whole generator is swapped out, but it sits underneath the skin. It's just a skin incision. It's like 20 to 30-minute operation. And then the third I would throw in there is system replacements, where you're taking out the old hardware and putting new hardware in, either due to lack of efficacy over time, or if there's some complication where you need to replace the leads. All of that can be done in the ASC setting. So the management of these patients, and this slide is a bit busy, but it kind of goes through what the therapy is. Where patients initially modify their diet, oftentimes this is just trial and error. If you look at gastroparesis diets, there's not one diet that works for everybody. People are very different. And then oftentimes they end up going to medical management, which, as you know, there's not a whole lot of medical management that can be done. We're a bit limited in the prokinetics, and everything else is just symptom management after that. So we get a lot of people with gastroparesis refractory to dietary modification and medical management, and they need some intervention. For nausea, vomiting, predominant disease, by and large, we recommend doing the gastric stimulator. If it's a stomach under pressure problem where it's an issue with volume, distension, emptying, then doing a pyloric intervention would make the most sense. You could have a whole talk for hours as to the appropriate pyloric interventions. Personally, I'm doing laparoscopic pyloroplasties in an ASC setting as well. And then sometimes after the stimulator, if the pylorus wasn't a problem to begin with, down the road, if you hit a wall, you can do a pyloroplasty to get them more responsive to the gastric stimulator. So if I do a pyloroplasty on a gastric stimulator patient of mine, and they're on high settings, I turn them down to the lowest settings and walk them through the adjustment process again over time. And then if I'm doing a pyloroplasty up front and they have refractory nausea afterwards, the nausea doesn't get better with their other symptoms, like the vagus is on autofire, that's where I would follow up and do a gastric stimulator. But having had the pyloroplasty, they're much more responsive to the stimulator much more quickly, and there are not as many visits doing the adjustments afterwards. So it's not a one size fits all. There's some step-by-step aspects to it. But for a lot of surgical practices, as you guys know, you're not operating on 100% of your patients. Whereas for me, I'm on average operating on over 100% of my patients because they typically get more than one operation over time. And if they're getting a gastric stimulator, the generator is battery powered, not rechargeable. So you have a future number of generator replacements you're doing for those patients. And then of the different surgical approaches, Enterra is really the least morbid. It has the lowest morbidity rate because if there's issues with it and you take it out, the anatomy is not altered. With pyloroplasty, the leak rate should be under 1%. It's not a big operation, but you can't reverse a pyloroplasty. If you do it in appropriately selected patients, you probably don't need to or want to, but still, you cannot reverse the pyloroplasty. And then there's bariatric surgery, depending upon what you do as far as how reversible it is or whatever, but obviously the morbidity goes up. And then some people are doing total gastrectomies, which I don't really understand doing that with the available therapies, because with the available therapies, it's just you should not be getting that far. And then if you look at Enterra specifically, in a study on the left of diabetic gastroparesis and on a study on the right of idiopathic gastroparesis, and just getting into the difference between the two is that about 25% of patients, in my experience, from my practice, have diabetes. That leaves about 60% of patients with idiopathic gastroparesis, and the remaining being post-surgical, like after Nissen fundoplication or after gastric bypass. Right. So if you look at the diabetic gastroparesis patients, there's a 68% reduction in the amount of vomiting that they have. And for idiopathic patients, an 87% reduction in vomiting. So that's huge for these people's lifestyle. And then a study of 157 patients at WashU, Enterra Therapy reduced hospitalization prevalence by 78%, and then total events by 91% within the first year after Enterra Therapy. So why do this in the ASC? You got these sick patients, they're in and out of the hospital. Why not just do them in the hospital? Well, as a surgeon, it's great to be able to do them in the hospital because I get more OR time. As you guys know, unless for some reason you live in a different world that I live in, getting OR time is one of the biggest challenges that you can have. And so going to the ASCs, it gets you additional OR time and greater efficiency where the turnover time is usually a whole lot better. Also, I'm seeing dramatically lower infection rates for device implants I'm doing in the ASC, whereas MRSA was a huge issue, me doing it in the hospital. And now I rarely see MRSA. If I do get an infection, which is rare, I can almost always clear it with antibiotics. Whereas before in the hospital, I was having to wash out the generators, pack in stimulant beads, sometimes take the systems out because we could never clear it. That is not what I'm seeing in the ASC. And then simpler processes as far as just patients parking in front of the surgical center. Oftentimes for an ASC, they're just getting there an hour in advance because the turnover times are more predictable. And then they're in recovery for just about an hour or for a generator, 30 minutes. So it's a very streamlined process. And patients far prefer the ASC than the hospital setting. So with some of the considerations that I've come up with over time, as far as who's appropriate for an ASC and who's not, some of these things will be obvious to you guys. But as far as starting off, I would just avoid anybody with home oxygen dependency. One, it'll avoid you getting canceled by your anesthesia colleagues when they review the chart a day before surgery, because no, that's never any fun, getting your cases canceled. Obviously, pulmonary artery hypertension is a big deal, but I kind of put this in where anytime you think you might need invasive blood pressure monitoring with an arterial line, that's not going to happen at an ASC. Portal venous hypertension for cirrhotics, I just wouldn't operate on them at all. And I'm a former liver transplant surgeon. What they need is liver transplant, not a gastric stimulator. Then hemodialysis or peritoneal dialysis dependency, they may be good when they come in volume-wise, but they may be overloaded and you're canceling them. You just don't want to be canceling cases at the ASC, particularly when you're getting going. And also for the ASCs I'm at, they can't check potassium in the pre-op area, so we just can't do it. Also, limited mobility, people with walkers, in wheelchairs, amputees, I wouldn't do at an ASC just because if after surgery they get up, they try to walk around, they can't because their core muscle, they just can't use that well, then you're having to admit them and transfer them to a hospital, which is not good. And then just surgeon-specific risk for conversion to laparotomy. I used to start off doing all these open because I was a transplant surgeon. We like maximally invasive surgery, not minimally invasive, but I haven't converted to open, knock on wood, for quite a few years now. And it's on people I've done transplants on, people I've done total pancreatectomies on. So really, it's just up to your personal comfort and experience. And then for new ASC program, just consider other things such as, having CPAP patients bring BiPAP machine. Some of these are common sense. One of the things I've done more recently, um, or in avoiding patients on daily opioids, they're harder to control in the recovery room. They're there longer, and that just disrupts the whole flow of the ASC. I've also, in the past 6 months, adopted an opioid-free postoperative management policy. I'm not using narcotics at all. I'll be happy to talk to you about that because that's dramatically changed my practice and how people do at the ASC. And then avoid patients on TPN or enteral feeds. These are your sickest people, and just it's more of a gamble, right? Even if they're young in their 20s, once they're on TPN or enteral feeds, you just don't know what you're going to get when you operate on them from a medical standpoint. And then if you have an existing program and you're just looking to expand into an ASC, you could start off by doing generator replacements, because the generator replacements, as you know, before the operation, they're super sick. They go to sleep, you replace their generator, you turn it on, they wake up, they immediately feel way better than they did before. And anesthesia is even like, wow, this thing really works. Whereas the systems take longer. It can take a few months of adjustments before they really start feeling it.
Good evening. Thanks, Dr. Hughes. Again, I'm the reimbursement specialist here at Enterra Medical, and I'm just going to provide a brief overview of the CPT codes and payment for the Enterra procedure. And as Dr. Hughes mentioned, again, January 1st, new this year, the lead placement code has been added to the Medicare covered procedure list, which allows both fully system implants and then also those IPG replacement procedures in the AS setting. So we are super excited about that. Enterra is a well-established therapy with broad coverage from Medicare and most commercial insurance companies. And then the published Medicare payment rate is $26,221. That's for a full system implant, which is the national average. In addition, we typically see higher payment rates from those commercial payers. And this is a younger patient population, and commercial coverage often represents about 40% of this patient population. And we do encourage you all to review those commercial payer contracts and consider not just a new system procedure, as Dr. Hughes mentioned, but also those battery replacement procedures, which represents about 50% of cases in most of the programs. So that's what I have for the reimbursement. And thanks again, guys. And I'm handing it back over to Dr. Hughes.
All right. Thanks, Tiffany.
Thank you.
Um, and as far as ASC readiness, what do you want to do to make sure everything's in place before you get going? Just logistical things to keep in mind is, as far as like skin incision to dressings on, it's about 60 to 90 minutes. If you have an ASC with a robot, you guys know better about docking. I've not used a robot for years, but apparently you're getting really good at doing the robots really quick. I'd like to do a robot because maybe I can operate until my 80s if I'm operating with a robot. And then the generator replacements are real quick, 20 to 30 minutes. Post-op recovery for a generator is probably 30 minutes, whereas the system's about 60 minutes. So when you're scheduling cases, what you probably want to do is start with your systems, because if you are not using disposable scopes, once you finish with the scope, they're going to want to process it. And the person that's having to process and clean your scope has to stick around until you're done with the case. So getting those done early so they're not having to stay late would be much appreciated by that staff. And then also, the generator replacements have a shorter recovery time. So the people at the ASC can't go home until the PACU is closed. So if you end with the generator with a 30-minute recovery rather than a 60-minute recovery, you're just keeping everybody happy. And for equipment, just standard laparoscopic capabilities, nothing special. And then you do need an EGD tower, or you can use the single-use EGDs. For the ASCs where I am at, I actually have a tower because there's a lot of GIs at the program where they do a lot of upper endoscopies. But at the hospital where I was at, we actually used a lot of the disposable scopes because you don't need to do anything. You're just going down and take a look. And then that was actually more cost effective for them than using the reusable scopes. And then as far as training, none's required. It's just whatever your credentialing committee wants you to do. And then if there is training that they want you to do, you can do it through Enterra. I'm available to help anybody out as far as getting these cases going, managing complications, all that kind of stuff. And then how does it really fit into your practice? So I have a certain preference because of how I do it and how I've done it before. And my perspective is when I was with the university, I was really just the technician putting them in, and the GI doctors would manage them. Whereas now my perspective is we get oftentimes sent patients before anyone's tried any medical management, and we're starting off with medical management before we're jumping to doing anything procedure related. And I'm fine with that because I get them from the get-go and take them all the way through, which I enjoy, and I'm a nurse practitioner, which makes it a whole lot easier. So the way I get the patients could be from primary care providers where their patients are struggling. They're not getting anywhere with their GI providers because they don't know much about gastroparesis, certainly not anything about Enterra Therapy. And then the PCP send them to you once they hear that you've been operating your patients. The patients go back, they look a whole lot better, and the PCP like, check out Dr. Hughes or Dr. X, right? ER providers. So when the ER calls me about a patient of mine that maybe has a wound infection or has vomiting post-op or whatever, I just tell them, hey, send me all your gastroparesis patients, and they share your number with every one of the providers in that hospital, right? Gastroenterologists are my main referring source, and it is kind of nice getting them from GI doctors because they're more fully worked up with an upper endoscopy, a gastric emptying study. Oftentimes they're trying them on prokinetics before they get to you. And then endocrinologists for the diabetics. I don't really get that many referrals from the endocrinologists, but it's good having buy-in from the endocrinologists as far as the glycemic management. A lot of these patients will get labeled as non-compliant diabetics, but I can tell you as a former transplant surgeon focused on pancreas transplants, these people just run themselves high to avoid hypoglycemia because that's what's going to kill them. And by putting the Enterra in, oftentimes it's the diabetics, we see the biggest improvement in as far as their overall health care because their diabetes management becomes much easier. And the endocrinologists really appreciate that. And then I also get referrals from surgeons, particularly bariatric surgeons, and those people doing foregut, Nissens, anti-reflux procedures with vagal injury or stress. And then who manages afterwards? Like I said before, personally, I prefer being the one doing it all. And it gets you into management of reflux. And so I refer patients back to myself for reflux procedures, particularly partial wraps or TIF make a whole lot of sense for the gastroparesis patients. And so this is how I manage patients post-op. There's not one clear pathway, but this has worked out well for us. So I see them 1 month after the implantation to do an adjustment if needed. This is within the global period, so you can't really bill for that unless you leave out the gastroparesis code and just bill for reflux or constipation or diarrhea or something. Unless you're doing a generator, the global is only 2 weeks. So you can actually bill for your visit at 1 month if it's a generator replacement. But after the new systems, I'll see them at 1 month and then every 3 months thereafter to do an adjustment until their symptoms are under control. And then we just park them there and then see them yearly until the battery runs out and we got to do a generator replacement. And so that's a fair bit of clinic volume, but with an advanced care provider, APRN, PA, it works out great.
Dr. Hughes, so first question that we wanted to throw your way is, what do you wish you knew about Enterra Therapy when you started that you know now?
So when I first started doing this solo practice, well, I guess to back up, when I first started doing this, we didn't have any pyloric interventions, and that made it more challenging when all we had was a stimulator. Having both options now, the management of these patients is far better. But as far as what I know, I guess I would say that if you're looking to do this off the bat, what I initially tried to do was just be a surgeon and place these and think the GI doctors would want to really take care of the patients afterwards. And what most of them really wanted was for me just to take care of them afterwards. So I think if I entered into it, I would just enter into the mindset that look, every patient I see, I'm going to medically address their gastroparesis as best I can, which as a surgeon, it's not too complicated. It's already drugs we're familiar with using. Um, and then two, address their gastroesophageal reflux disease, which again is potentially an opportunity for further intervention. And then I had to learn a bit about managing diarrhea, constipation, small intestinal bacterial overgrowth, but it's just not that hard. And how you manage those things is a little bit different with gastroparesis.
Great. Thanks, Dr. Hughes. A related question that I would like to ask as a follow-up that we hear a lot is, what are the most common misconceptions about gastroparesis and the patients that you treat that have gastroparesis?
That they're all crazy. So, what I learned as a transplant surgeon, because in transplant, we had very ill people. And I had a good friend of mine that was our transplant psychiatrist. And she would point out when we have these patients that are extraordinarily challenging to deal with, is that when you've exhausted your physiologic reserve, your psychological reserve is also exhausted. And patients that are otherwise normal, that are miserable for a long period of time without relief, tend to resort back towards primitive defense mechanisms. And it looks a lot like personality disorders. But she taught me how to deal with them, where you just have to very firmly go to them like, look, this, you can't treat my staff this way. This is inappropriate, where you set boundaries and limits with them. And then by and large, they would be apologetic. They would reset. They'd be so appreciative. And those that don't are maybe like 2% of people, where they ramp it up, and you don't really want to operate on them anyways, because those are the ones that truly have some severe dysfunction. And I think once you are comfortable dealing with those challenging patients, this is not that hard.
Makes sense. Appreciate that. Um, Another related question, but a little bit different, this one is, how do you handle the complexity of gastroparesis patients and the workup or lack thereof that's brought to you when these patients walk in the door?
Well, really, it's not that complex. I mean, you need, and I can see why it is, because they have a whole lot of medical issues, but because so many are young, we're not dealing as much with severe coronary disease or severe lung disease or dialysis patients, right? They're younger, and it's just this is their only thing making them miserable. So in that way, it's a bit easier. And the workup really, you don't need a huge workup. All you really need is an upper endoscopy showing no mechanical obstruction from an ulcer or a tumor, which, as you guys know, it almost never shows that. Nearly everybody has antral gastritis, which I think is probably the inflammatory process leading to idiopathic gastroparesis. That may be an autoimmune thing. And then following up with a gastric emptying study. And also, what I've found out over time is that these gastric emptying studies are very unreliable. And I think it's useful to have one that's positive and delayed, but it doesn't matter if it's the most recent one. It doesn't matter if it's an old one. I would just say if it's any gastric emptying study that's delayed, then you're fine. If you have multiple gastric emptying studies that are not delayed, then you might want to be careful. But I have gotten to the point where I really treat those the same. Technically, it's functional dyspepsia, but that's just a different, longer conversation with patients. And I'd be happy to talk to anybody online that wants to go into that territory. But I think when you start this, I would start with people that are delayed, particularly at 4 hours for solids. But really, and it doesn't have to, they don't have to all be delayed. They just need one study that's delayed.
Makes sense. And when we did have one question submitted, I know you touched on this a little bit during the content of your presentation, but could you just again describe your patient selection criteria and which are the patients you would potentially rule out for gastric stimulation?
Um, so first of all, I would not place a gastric stimulator on patients without nausea vomiting. We do have a subset of gastroparesis patients where it's all bloating, fullness, and pain. And I would not do a gastric stimulator for them. I would do a pyloric therapy. Um, for people where this is a little tricky with marijuana use, and medical marijuana, recreational marijuana. In Kentucky, we just started doing medical marijuana. We don't do it in our practice, but the majority, I'd say probably over half our patients use medical marijuana, and it's one of the indications. But you have the hyperemesis syndrome associated with it. And what you don't want to do is the person that's smoking a lot of pot, where they find relief and they have a lot of abdominal pain with the nausea, vomiting, they're not too delayed, and they get relief in a hot shower, right? That's not somebody you want to do. That's the, cannabis hyperemesis syndrome.
Yep,
That's
makes
not a
sense.
lot of people though.
And just to as a follow-up there, would clarify Enterra Therapy is, specifically indicated for those with nausea and vomiting as a result of gastroparesis.
Right.
So from that front too, just want to make sure we're clear from that one. Um, Another question that was submitted to Dr. Hughes is, what steps would you recommend for those wanting to start implanting and building a program within an ASC? So, would like tactically, what are those first steps?
So the first steps is you need to get an IRB protocol, which Enterra is very good about helping you out with. For those of you that haven't set up, and for those of you that have set up an IRB protocol, you're like, I don't want to do that. It's a ton of work. For those of you that have never done one before, you're like, I don't know, that sounds kind of fishy. I don't know if I want to do that. But I did almost no work whatsoever in setting this up because it's an IRB for humanitarian use exemption. It's not a standard research IRB, and Enterra has this all very much ironed out. So I wouldn't really look at that as much of a barrier. It does take some time, but if you use, like, for example, I use the Western IRB, they meet 3 times a week. I mean, they can get an IRB protocol through in like 2 weeks. It just doesn't take that long. So that's the first step. Well, I guess first step is getting buy-in by your center, and that's going to be mainly explaining that you're going to be doing the lower risk people initially till they get comfort with it, but then getting the Enterra folks to go talk to them about the financial considerations. And they're very good about going to help out. They'll go physically meet with them, presentations about what the reimbursement will look like for that actual area. And it's very convincing data. So once you have that set up, then it's setting up the IRB, then it's just scheduling the cases.
Makes sense. Um, And then what I love those first few steps because that is definitely something we go through with all of our new programs. The other part of it that I would love to hear your perspective on, Dr. Hughes, is how important is having a gastroparesis team in the ASC? Is there anything you would need to do or think about getting a surgical team up to speed when starting an Enterra Therapy program?
Yeah, so I didn't specifically ask for a specific team. I mean, as far as the scrub techs and all, it's not that big of a deal. It's more the anesthesia providers. And ideally, what you'd do is have, one or two of the CRNAs doing these cases and getting more familiarity with them, and then talking to them in advance about what protocols you can do to lessen their workload, right? Like for me, a lot of it, and it was later on. I mean, it'd been nice if I had done it early on, but I didn't know about it. I don't think the drug was available. Doing Jornavix, which I do now to replace the opioids. So I don't use opioids, and I give gabapentin a day before and the morning of, lessen post-op nausea, vomiting, and do all those different steps. And also worked with them to, like, they come up with ideas too. Like they're in their literature, given a gram or two of magnesium infusion during the case can help. So they do that. And now Tylenol, IV Tylenol is cheap, so now they do that. And then given, Toradol or IV Motrin at the end of the case, when you're done and you're closing the incisions, given a dose of that. So just talking with them about all those different ways so that in recovery, the PACU nurses aren't freaking out because they got a sick patient back there.
Makes sense. All right. Well, just to continue on the journey, once you do have an Enterra Therapy program up and running, I would love to hear about where you get your referrals for gastroparesis patients and Enterra Therapy. Is there anything that has worked well for you to help your patients become aware of this option?
So, being owning my own practice, I have a lot of flexibility with what I can do. And I get a lot of referrals off Google from our webpage. Um, Facebook, as far as social media, has the most engagement. There's different Facebook support groups for gastroparesis, which you don't see on Instagram. I know a lot of businesses find Instagram to be more useful than Facebook, but for this, Facebook ends up being much better. I've not really found LinkedIn to be a great way of generating referrals from referring physicians, but the Facebook stuff ends up being great, particularly putting up pictures of patients that have done well afterwards, like a graduation pic, with a caveat that, no one really graduates, but them seeing patients up there that are taking a picture and smiling because they feel great is means a whole lot. And that drives the traffic to your website. I used to do a monthly webinar. One of the things I do that's probably the most important thing to help with patient satisfaction is I give a weekly online educational seminar for all our gastroparesis patients, all new ones coming through. So by the time they're coming to see me, they want something done yesterday rather than coming in nervous and upset. So that's probably the biggest thing. But if you're not doing gastroparesis full time, it may be hard doing that, right? Maybe you do it once a month. But doing
Yeah,
all those different things ends up being useful. But you can get a lot off Google and Facebook.
that makes sense. And I liked what you said earlier, Dr. Hughes, that, if you're looking for these patients, you can fill your schedule with them. As as a organization, that's what we find as well, is these patients are still seeking options, in most cases around the country. So I like
And
that sentiment.
I forgot to mention, which is a miss of me, is that Enterra has a provider page, right? So they'll have people reach out to Enterra about how do I get the therapy, and they actually have ambassadors, Enterra medical ambassadors, I think you call them, right?
Yep.
Yep. That end up being like, oh, you should talk to Dr. Hughes. We've met him, so they kind of know us, and then they refer us patients.
Makes sense. And I want to follow up too on your monthly webinars, Dr. Hughes, because we do a fair share of patient education as well, but curious what type of information you cover during those programs and what seems to be most helpful for patients.
Showing them pictures of what their stomachs look like in the OR. So, when they see a big, giant, dilated stomach full of swallowed air, that's kind of purple and dusky, they're like, okay, I can see why that hurts, right? Because they're not getting enough blood. Showing what a stimulus looks like in a patient, showing the different steps of the operation. And then also, whenever I operate on somebody, I know different surgeons are different, but I take a lot of pictures in the OR and give patients the pictures. So they're like, they don't feel like anything's been hidden, and they know exactly what's been done, and they really appreciate the pictures. And then also, I'm religious about making sure every provider that's associated with that patient gets a copy of my operative note or clinic notes. I have specific cover pages that explain how I manage patients and work them through so that when the referring doctors refer their patients, they know kind of what to tell them to expect, which they really appreciate rather than just saying, I'm going to send you to Dr. Hughes and he'll figure it out for you. They'll be like, no, I'm going to send you to Dr. Hughes. He figures out, whether or not there's any other medications. If you're talking about surgical therapy, he'll look at caloric therapy for this. He'll look at Enterra therapy for this, because I spell it out for him. And then I send them the operative pictures as well, so the referring doctors can see what these operations actually look like.
That's really cool. And that's something that's been powerful for our therapy as well, too, is just closing the loop with our referring physicians, between also the implanting surgeons, because a lot of the times, physicians may or may not ever hear how that patient's doing. And if they're doing well, they probably never come back. So I think that's a really cool thing that you do as well. And also, I just wanted to clarify our patient education team and ambassador team. So we have for the group, we have two types of patient support. We have patient ambassadors who are people who have actually gotten Enterra therapy and are willing and volunteered to share their story with patients who are considering it as an option. And then we also have patient educators who are part of our entire organization. They talk to patients all day long. So they answer questions and then they share available providers in their area. So once patients select their provider of choice, the educators can put the patients directly in contact with that provider. So that's just one resource we also have to help patients find their care. Um, Another question I'd like to ask you, Dr. Hughes, is what are some of the most common questions patients ask you when they're considering Enterra therapy, and how do you typically address those questions in your practice?
Well, it's hard to say like one thing or another. but I would start off by saying that they don't understand why they feel the way they do. Like they don't understand the connection between gastroesophageal reflux disease and gastroparesis. They don't realize that their alternating constipation and diarrhea is very likely associated with their delayed gastric emptying, right? And that if we can get all those things normalized, their downstream things end up getting better, heartburn can get better, all those sorts of things. And then I can't really understand that unless you show them pictures. Like pictures are so critical, and pictures from the OR, as surgeons, we have a tremendous amount of resources in just what we see every day, right? And by taking a lot of pictures and sharing the pictures with patients to tell a story, then they understand why they feel the way they do. So then they understand why doing what you're proposing to do actually makes sense. But then they also understand why, if it doesn't work, why maybe it doesn't work, right? So they got to really understand that going into it to be buying into the whole process. And obviously, some people you can talk to them until you're blue in the face and they never really get it. And some people get it really quick. So it's being able to speak to your patients in a fashion where you're not talking down to them, you're empathizing with them, and then you're showing them you really understand why they feel the way they do and that you want to make them better. Because they don't hear that from anybody else.
Yep. Yep. I love that. Um, Wanted to dig into, I know you shared a little bit about just why the ASC may make sense. And of course, it's obvious in some cases, and many of our physicians here today know the ASC well. But can you talk a little bit more about what is the patient's perspective regarding a procedure in the ASC setting? Do you think the ASC environment helps you treat patients who may have otherwise have been hesitant to navigate a large hospital system for a neuromodulation procedure?
Um, well, patients will go wherever you tell them they need to go. But, I have plenty of patients where, I put in their stimulator at the university hospital. And then they follow me to my practice and I do it at the ASC and they're just loving the ASC and the fact that they're coming to my office, not having to go to the university. Um, I don't know if I get anybody that really would hesitate moving forward with the therapy, but when you're talking to people and you're trying to explain to them the downside of getting the operation, one of the downsides is like where you're going to do it. If you're doing it in a very easy to get to surgical center, um, that is significant for some people who don't want to go downtown. A lot of my patients, I mean, Louisville's not big, but for a lot of my patients, Louisville is very big and scary, and going downtown is very forbidding. So the fact that I'm like, yeah, the ASC is right next door. When you walk out in the parking lot, your car is you're sitting right next to ASC. That makes it much easier for them.
Yeah, no, makes sense. Um, I want to also follow up on a little bit of what you talked about just a minute ago about managing your patients' expectations and counseling them before a procedure. So, how do you approach that counseling and expectation setting in general prior to an implantation?
So, um, the way I explain it is that I view, once you get to a failure of diabetic um, dietary modification and medical management, and you're talking about a procedure, I tell them I look at it as a staged approach, with stage one being whatever you're starting with, being the Enterra in this example, stage two being a pyloric therapy if they have residual symptoms, or reintroducing medication that maybe didn't work before. So if you get a patient where you do the Enterra and they have refractory nausea, but they get some better, what we oftentimes do is we may reintroduce a prokinetic so they can manage their symptoms at home rather than coming in for an adjustment. So we let them know that that could be the next step, or the next step could be a pyloric intervention, that it's a process and you may need to go from step one to step two to step three to step four, or you may be good after step one. Everyone's different. And we just have to work through it. There's nothing in our crystal ball that'll tell us what we need to do up front. Otherwise, I just do it all at the same time in the OR, right?
Yep, makes sense. I appreciate that insight. Um, Also, you mentioned that you have healthcare providers often referring patients to you for treatment. Would love to hear from that perspective. What are the most common questions you're hearing from your referring providers about gastroparesis patients and Enterra therapy?
Um, well, it's interesting. The questions I get sometimes are surprising. They're like, "So can you do Enterra after a Nissen fundoplication?" I'm like, "Yeah, we do a lot of Enterras after Nissen fundoplication with good results." Another one would be like, I got this patient, but their A1C's 8. I really want their A1C to get down before we're sending them to you for therapy. And I'm like, look, don't worry about it. These people are scared to tightly manage their blood sugars because they're going to end up getting a blood sugar of 30 in the middle of the night and having a seizure, right? They just need to get their gastroparesis better so they can move away from a diabetic diet, move away from a non-diabetic gastroparesis diet to a diabetic friendly diet, better manage they can better time their insulin and get things under control. So that's where what I found is that a lot of referrings, they're hesitant to refer some people that maybe they think are too sick or not appropriate. And that's why I try to get every one of my providers' cell phone numbers and I text them like after I operate on them, or if I see them in clinic or I have some issue with them, I reach out so that by doing that and breaking the ice, then they're much more likely to reach out to me.
Yeah, I like that. And let's see, we just had another question submitted from the audience. So, if a patient is diagnosed with both GERD and gastroparesis, which disease state would you address first and why? The options posed here were Intera first or a hernia repair and fundo first.
Yeah, so I've seen tons of people with like, you know, free Nissens with delayed gastric emptying. The way I look at it is that if you have delayed gastric emptying and you do a fundoplication, you're creating a closed loop obstruction. And if you're going to blow out one end or the other, you're going to blow out the wrap. You're not going to blow out the pylorus. So I never do an anti-reflux procedure until I have normalized their gastroparesis and got their emptying normalized because I just worry about the wrap failing. And also doing a full 360-degree wrap, I have worries about because even if somebody is asymptomatic one day, they may get a flare of gastroparesis and then blow out the wrap. Whereas if you can do a 270-degree fundoplication, either as a TIF, C-TIF, or a partial fundoplication surgically, then you may be better off regardless of motility, esophageal motility studies. So that's the way I view it. And honestly, once I get their gastroparesis better, oftentimes their heartburn's much easier to manage. But as I do more and more of this over time, my anti-reflux procedure population is going up just because my overall population is going up.
Makes
So
sense.
again, it's like your own referral source for many things. Thankfully, I almost never have to do J tubes.
Got it. Okay, then we have a follow-up to that one, Dr. Hughes. So the question is, so how long after you do an Intera would you bring a patient back for an anti-reflux procedure?
Depends on how long it takes to get their gastroparesis under control. I mean, it could be you put their stimulator in and their nausea, vomiting go away, their emptying normalizes, their heartburn doesn't, and then you do the anti-reflux procedure within a year. Or it could be that it takes a year of adjustments, and then you can't normalize their emptying with the Intera, and then they develop bloating, fullness, and discomfort, and you're doing a pyloroplasty on them, and then they normalize, and then their heartburn's out of control, and then you're doing an anti-reflux procedure. Then you're doing, yeah, anti-reflux procedure on them. So it's different. I don't have any hard and fast rules about weight and whatever. I would not do anything before 3 months. And honestly, I'd probably give it a year to make sure that you got the adjustments and their symptoms have been stabilized for some period of time because the symptoms fluctuate in nature. So that may be good for 6 months and then have a terrible flare um, and blow out your wrap where it slides.
Got it. Makes sense. Want to circle back to the perspective of the referring physicians you work with. What information is typically most helpful to receive from the referring providers before you evaluate a patient uh, for possibly getting into therapy?
The three things we ask for is just their most recent clinic notes so we know what they've tried. And so that when we talk to the patient, um, we can make reference to it so they know that we've actually read their chart, and then they feel better that we know what we're talking about. And at least one, ideally all their gastric emptying studies, and then not all their endoscopies necessarily, but the most recent upper endoscopy.
Got it. Got it. Okay. Makes sense. Um, Want to switch topics a little bit to the actual workflow in the operating room. So, what does a typical day look like in the ASC when you're performing, a number of Enterra therapy procedures? If you like to stack these, or what does the workflow typically look like for you?
I mean, like, how many am I doing?
Yeah, I guess just speaking in a little more detail of, how you like to schedule these and who's involved and what else you might have in a typical day.
Yeah, so it's highly variable. I mean, I could have a day that, so first of all, when I was at the university, the most I could do of any case, doesn't matter what it was, is three. So at the ASC, the most laparoscopic cases I can do is I could do six straightforward pyloroplasties in one day. So those are the two extremes. Okay. The stimulators being a little bit longer, I could do probably four systems in a day without anything else. Um, so it's just variable. It's just when we schedule them, usually we try to do the stimulator systems first to get to be done with the endo. And then if I have pyloroplasties, then we would follow with the laparoscopic pyloroplasties. And then the generators we would do last, kind of like we talked about, because then they have a
Yep.
um, shorter time in recovery.
Okay. Makes sense. Um, and moving on to post-procedure, uh, what is the criteria used to assess whether enterotherapy is benefiting a patient over time? And at what point, do you kind of make the call if enterotherapy is working well enough for any particular patient?
Yeah, so when you're doing the adjustments, you're going off symptoms, primarily their nausea. That's the easiest thing to guide. It's harder to guide therapy if you're going off the bloating, fullness, and discomfort. Um, I mean, regardless of the fact that it's indicated for nausea, vomiting, just practically speaking, it's easier to assess the nausea. And what I do is I'm very specific when I'm talking to patients in clinic, and I make sure the nurse practitioner does too. They say they're nauseated. Okay, are you nauseated every day? How many times are you nauseated in a day? Okay, you're nauseated a few times a week. How many times per week are you nauseated? Because you document it. Because they're not going to remember when they see you 3 months later what they felt like when they saw you in 3 months. So you really got to pin them down as far as we use a gastroparesis symptom score, which is okay, but it's how people fill that out unless you sit down and walk them through it, has some limitations. Whereas specifically, if I ask them how many times are they nauseated in a day, how many times are they taken Zofran, how many times were they throwing up in a day or a week, right? Because some people be like, "Oh, I feel horrible, miserable." Okay, how many times are you throwing up? Oh, I've only thrown up once in the past month. Another person be like, "Oh, I feel great. I'm only throwing up 4 times a day." Right? So that's where you got to get into the real numbers to figure things out. Because if you're seeing them 3 months later and they told you 3 months ago that they were nauseated 4 times a day and they're vomiting once a day, 3 months later, after an adjustment, then they're vomiting the same number of times per day and they have the same amount of nausea. Bumping them up one step in your settings doesn't really make any sense. We'd bump them up like 2 steps, be more aggressive with the adjustments. And then in the next visit, if they're no better, then you're like, okay, we got to reset. And then we want to consider potentially adding back a prokinetic, doing something else, figuring out, are we dealing with, small intestinal bacterial overgrowth? Do we need to do a pyloric therapy? I don't usually use gastric emptying studies for that. The one place I'd use a gastric emptying study is if somebody, like I've done a pyloroplasty, I've done a stimulator on them, and they're still struggling with bloating and fullness.
Just one last question I would like to ask you is what excites you most about the future of gastroparesis care and your practice of treating these patients?
Um, I don't know, excitement so much as like black box open horizons is the better understanding the immunologic dyscrasia that's going on and likely driving a lot of gastroparesis. So, in the idiopathic group, and maybe this is because I'm a transplant surgeon, um, 60% of people are idiopathic. In that group, about 90% are women. Whereas in the diabetic group, it's more evenly distributed between men and women, right? And so that's similar to what we see with autoimmune disease. We see a ton of autoimmune disease in this patient population. And what's the best way to actually manage these folks over time? And we just don't know. There's like 4 antibodies we check now: anti-GAD65, voltage gated potassium channel, voltage gated calcium channel, um, anti-acetylcholine receptor antibody, and then some other things as well. And the panel keeps on expanding over time. But like, what do you do once you actually find something? It's kind of hard. So that's like one thing. But also, what's exciting to me, what's here and giving us more answers, is additional technology like allometry. Being able to more accurately phenotype these patients. And for those of the guys that don't know what it is, allometry is ALIMETRY. It's like electrogastrography for the stomach, and it potentially can phenotype patients better to, one, let us know response before and after therapy. You can actually look at their tracings to figure out what got better, what didn't. But then it's more information rather than just going off patient symptoms as far as what therapy makes the most sense.
That's awesome. Thanks, Dr. Hughes. And I think, from our end too, we're seeing lots of exciting research on, the disease state and technology alongside it. So lots of good
Well, I
stuff.
should say, to give you guys a shout, Medtronic had this for 24 years, right? And upgraded it once. And you already came out with new leads that I put in last week. You're coming out with a new generator next
Yeah,
year.
yeah, very
There's
exciting.
to be Bluetooth capability where they can check it on their own, then potentially remotely program it. So where you can do a lot of telehealth for programming and patients don't have to come back in. So that'll be great.
Yeah, no, exciting stuff. All right. Well, thanks so much, everyone, for the time. And thank you, Dr. Hughes, for a great presentation and answering all the questions we had come in. So just want to quickly mention for all those who attended, if you have questions or are interested in learning more, please reach out. We're happy to connect you with a number of resources we have available. So it can be your local therapy consultant to learn more. Our medical education team has tons of resources for you, as we mentioned. Tiffany from our health economics team is happy to have a conversation. And Dr. Hughes occasionally does one-on-ones with physicians to talk about, details for your specific practice as well. So happy to connect you with any of those resources which may make sense. And thank you again for your time. Have a great rest of your Monday night.
Thanks, guys.
All right. Thanks, everyone.